Down there or over here?
I'm going to like this. That's fine. Do you need an apple cart?
Yeah, dito na
Dito ka na lang kaya. Kamukha niyo isa.
Small but very good.
Okay, please set up the timer. So, good morning and good evening to our folks in the Philippines. Thank you to ASA President, Dr. Maria Santo Domingo, and co-organizer Dr. Senatina for the invitation to talk about updates on long COVID. So, as mentioned by Ma'am Leia, my day job is studying cancer-causing viruses. That's my day job. But when the pandemic broke, apparently it became cool again to become virologist. So I took on the job of like educating other people about what's going on, because there was just an influx. We didn't know a lot, right? And there was an influx of new preprints, and the publications came so quickly. So my job was like to integrate everything and present it in a way that's digestible to the audience. So last time I gave a talk on long COVID, I think was 2021, ma'am, right? I'm Giselle, yes. And there has been a lot that has been happening since then. So, okay. Okay, just my disclaimer. And so my goal this morning is to try to convince people that we still need to study long COVID, even with the end of the pandemic emergency. So that's my first job. And then I want to go in and define long COVID. When I first presented long COVID, it was just like a laundry list of symptoms. It was like 100 symptoms, and people were like, why is it so many symptoms? So now there are actually people who are organizing this by clusters and all that, and we're going to go into that, the definition, and look into some hypothesis of the pathogenesis. Why is this happening? And that way, with having a pathogenesis in mind, then we can have some targeted therapies, right? And we're actually going to do a little bit of a deep dive in one of the most recent studies. This one came out in Nature Communications, I think, from Eva Harris's lab, who usually works on dengue. And I think she did an awesome job in describing how the spike protein affects endothelial function. And then in the end, I'm going to come into some possible modifiers of long COVID and there. Okay, so why do we still need to study long COVID? So as of May 2023, pandemic is done. The WHO declared it done. The CDC said we're done. Why? Why are we still into this? And the reason I think is because endemic does not equal harmless, right? People are still getting sick, and people who have been sick of long COVID actually are still experiencing symptoms that are impacting their day-to-day life. And because of that, they're not able to go back to their jobs. So like maybe, let's say if 10 to 30% of people who get COVID get long COVID, right? Those 10 to 30% of those people, about 50% of them are unable to go back to their regular jobs. And that's a lot of people. And that impacts, your own personal economics, right? Economic impact, your personal life. Like you can't earn anymore, right? And somebody has to take care of you. You have to see your doctor, like, I don't know, every week. And then from that level, that also has a national impact and a global impact, because now there's a bunch of people who cannot work or live their life, So that is a quality of life issue, but also I think it's something that we really need to look into to help them, adapt to this new disease, I guess, that's happening in their bodies, and at the same time recognize this, that it really is a disability. In the those who have COVID are struggling to get disability payments, because I think there's some push right now that try to code these conditions so that these people can get some disability checks just to tide them over until they get better. Okay, so what is long COVID? So previously we were calling them, long haulers of COVID. It basically represents a wide range of symptoms. Oh, hold on, I forgot to put the pointer. Can you see the pointer? Yes, okay. Wide range of symptoms that are outlined here in this schematic, and here it's outlined by organ system, and you have the symptoms in the red box and the possible pathogenesis in the blue boxes, so really wide ranging. And it's been called post-acute sequelae of COVID-19, so we're past. The WHO calls it post-COVID-19 condition. So that manifests 3 months from onset of acute illness and lasting for at least 2 months. And the descriptions of the symptoms actually have a lot of commonalities with other post-viral illness, such as chronic fatigue syndrome. So it's actually nice. So we can try to see what research has been done for these post-viral illness. But in terms of mechanisms, actually, we don't know a lot yet about these other post-viral illness. We just know that it's there and what's happening. And so I guess the good news here is that for the more recent COVID waves, the prevalence of long COVID has been lower than the first waves of COVID. So there has been, like I mentioned earlier, there's been an effort to categorize the symptoms. And this one is from the UK COVID study group. And they try to differentiate the post-COVID-19 syndrome from the ongoing symptomatic COVID-19 based on the timing. So if it's symptoms from 4 to 12 weeks from start of illness, then that's still a symptomatic COVID-19. But anything that is more than 12 weeks, that's what they call long COVID, and they call it post-COVID-19 syndrome. And their group categorizes it into these clusters. So they're actually not the only group that does the clustering, but I felt that theirs makes a lot of sense. So they group together the cardiorespiratory cluster together, and then the neurological, central neurological cluster, and then the multi-organ inflammatory cluster. So I'm going to go back to the cardiorespiratory cluster when we talk about the paper. So long COVID has also been reported in children, okay, and the most common symptoms are mood changes, tiredness. Tiredness is also seen in adults, as you remember. And according to this paper, myocarditis is the most common diagnosis for kids that have been diagnosed with long COVID. And the prevalence differs depending on who you read. So that JAMA Pediatrics paper said it's very low in children, very low, much lower compared to adults who, adults is 10 to 30%. But this other paper was saying it's actually 25%. So let's call it a range, right? 4 to 25% of children who get COVID-19 get long COVID. Okay, do babies get long COVID? I think someone asked me this question. Maybe Ma'am Giselle, you were the one who asked it, okay? So, and we're talking about babies born from mothers who got sick of COVID-19 during pregnancy. And the answer is yes, maybe, because the babies who were born were diagnosed with neurodevelopmental delays. 6% is the prevalence within 1 year of birth, compared to babies born from moms who didn't get sick, which is 3%. So that's like a twofold increase in diagnosis of neurodevelopmental delays that is associated with the COVID-19 pregnancy, during pregnancy. And the highest risk is during third trimester. So what causes long COVID? So I like this schematic because it outlines the major hypotheses that are out there. So one of them is viral antigen persistence, and based on autopsies of patients who have passed away from COVID-19, they saw RNA of SARS-CoV-2 in all tissues of their body, like everywhere, brain, gut, just whatever they looked at, SARS-CoV-2 is there. So apparently SARS-CoV-2 RNA can go in a lot of organs, and I think it's because ACE2 inhibitors are more ubiquitous than we thought, okay? And then this one is systemic and tissue-specific inflammation, We know about this already, and this makes sense because the acute COVID illness, especially the ones who require hospitalization, do have this dysregulated inflammation profile. The next one is human herpes virus reactivation, specifically EBV, which I also study. And this one is a little bit controversial. Some groups would say, yes, we see it. Some groups would say, we don't see it. So let's see, we need more studies. The next one is dysbiosis, specifically in the gut. So there is some kind of dysregulation happening in the microbiota of the gut. And it's also been proposed that the gut is one of the reservoirs for the virus. And then here we have microvascular dysfunction, and I've talked about it previously that those who have had COVID-19 are actually more likely to have blood clots because there's some components of the blood clot that are like overexpressed, and this causes as the nucleus for start of a clot for these patients. And then lastly, these autoantibodies. Okay, so going back to the cardiopulmonary cluster. Okay, so cardio, so heart and lungs. So in this column we have the symptoms and the diagnosis, right? And then here in the middle are the possible mechanisms. So endothelial cell dysfunction. So as you know, the endothelial cells are the lining of our blood vessels. So if those are somehow dysregulated or destroyed, then we have a problem. We'll have some leakage in our blood vessels. And then cardiomyocyte injury, so your heart and lungs are injured, so there's like fibrosis and all these things happening. Okay, so I will concentrate on the endothelial cell dysfunction. So the endothelial cell injury. So what is causing the vascular leakage in the context of COVID-19? And that can lead to long COVID. So like I mentioned, there's this group that usually studies dengue, and they went and looked at SARS-CoV-2. And for this particular study, they looked at just the spike protein, not even the virus. Okay, they just had a bunch of spike protein and then threw it on some of these human pulmonary microvascular endothelial cells. And what they saw is that when you have the spike protein added to these cells, okay, so here, so this is your negative control, and they are looking at the endothelial glycocalyx layer. So you have your endothelial cells, and then you have this like layer of protection of the cell that are made up of ligands, right? And so these are the types sialic, heparan sulfate, hyaluronic acid, chondroitin sulfate. So that's the untreated cells. When you add the spike protein, look, they disappear. They become slower. So that means that protective layer on the endothelial cells are lost. And then they hypothesize maybe because there's the degrading enzymes are being upregulated. And true enough, they look at the EGL degrading enzymes, right? Untreated, you see some signal, it's not zero. But with the addition of the spike protein, it actually causes an increase in these enzymes. And of course, if you have the degrading enzymes, for instance, hyaluronidase, then of course, you're going to have less hyaluronic acid and that EGL layer is destroyed. So they did this in endothelial cells. They also did this in epithelial. Okay. And then next, they use this dermal leak model. So it's an in vivo model wherein you have a mouse, you shave the fur of the mouse, and you do an intradermal injection of the spike protein. And at the same time, they do an intravascular injection of dextran with fluorescent tag. And they want to see the extravasation from the blood vessels, right, with the treatment of spike protein. And this is what we see here. So under the fluorescence, and then they use, I think, a Lycor software for this. So PBS, that's your negative control. Positive control is NS1, which is dengue protein that causes extravasation from the blood vessels. And indeed, the spike protein at 10 microgram and especially at 25 microgram, you see this the dextran, Alexa, fluorophore now going into the dermis from inside the blood vessels. So indeed, there is a leakage of the blood vessels in these mice once they're injected with spike protein. And it's spike protein only, not even virus, just the spike protein. And this is just a quantification for that. Okay, so they did RNA sequencing of these endothelial cells, treated or untreated with spike protein, and then they did RNA sequencing. They saw differentially expressed genes, and when they did a pathway analysis, the TGF-beta signaling pathway was up, and also the focal adhesion complex was also stimulated, and is the complex that connects to the extracellular membrane via integrins. So integrins. So they looked at integrin, looks like it's required. So basically, you have your negative control, right? And then if they add an inhibitor of integrin, this is what it looks like. With the spike, again, we know there's vascular leakage. Spike and integrin inhibitor, it goes down. So it looks like the spike protein needs the integrin for this vascular leakage. And then they also look at TGF-beta, SB431542. It's a small molecule blocker of the TGF-beta signaling, and they do the same experiment with the spike only, and the spike and the TGF-beta inhibitor, the vascular leakage goes down. So indeed, it looks like the SARS-CoV-2 spike protein is sufficient to interact with the integrin and the TGF-beta to disrupt the proteoglycan, this EGL layer on top of the cells. And like I mentioned, they didn't just do this for endothelial, they also did this for epithelial cells. And once this is disrupted, now we're going to have some hyperpermeability in these cells, and that's causing the vascular leak. Okay, I'm going to go faster now. Okay, so what about long COVID and COVID vaccines? So there's a study that showed that the prevalence of long COVID is lower in people who were vaccinated prior to contracting COVID-19. Paxlovid may have a use. So the use of ritonavir during acute infection reduces the risk of long COVID in patients, regardless of vaccination status. And also, unfortunately, for this particular study where they looked at medical records of veterans in the US, for infection with SARS-CoV-2, there's a cumulative effect. It results in substantial additional risk to getting long COVID during each subsequent reinfection. So in conclusion, I think we still need more mechanistic studies because we're still at the very beginning. Ongoing efforts to minimize reinfection. There might be a utility for Paxlovid. And then right now, defining management for subsets of patients with long COVID. With that, I end this talk. Thank you very much.
We have time for a couple of questions. Anyone? Yes?
So, thank you very much, Krista, for that enlightening lecture. Going back to the microcirculation, which is, of course, my favorite organ system. But my question now is, what about the sex differences in long COVID and the symptomology of that?
Yes. So it looks like from the surveys of patients they did, females predominantly are more affected by long COVID. And yes, they do report more symptoms, especially like fatigue and brain fog and all that. Yeah. I haven't come across any papers yet explaining the difference between the sexes, but definitely, yes, female predominance is a risk factor for long COVID.
I think in addition to the female dominance, females have more of the cardiopulmonary, whereas males have more of the kidney.
Okay.
Renal dysfunction.
Has there been a study on ethnicity?
Yes, Hispanics, being Hispanic is a risk factor.
Does that include Filipinos?
I think we get lumped with the Asians. Yeah, so.
Yes.
That's a good point. I haven't come across any papers that was looking at like occupation, but I imagine like with healthcare workers, right, being the frontliners, and a lot of Filipinos being in the healthcare occupations, I bet a lot of them got infections, reinfections. So
I was also looking at that leakage test that you had. You tested with vaccinated, there's still going to be incidences of cardiovascular leakage.
oh, the vascular leakage. So the vascular leakage studies were done in mice and cell culture. So not really looking at patients, although this paper was proposing, using some of these inhibitors to possibly help mitigate the vascular leakage in patients who, if they come and present with COVID. Yeah, but no clinical trials yet. That's how early we are. Yeah, just starting. Yeah.
So with that, let's.
Yeah, just interesting about the pregnant women.
Yes.
And so if you are just starting your pregnancy, and then you go through that COVID, and you go through it throughout the pregnancy, what's the effect?
I think in terms of pregnant women, I think I'm not a clinician in the US, I am in the Philippines, but they recommend, like the gynecologists would recommend, like get the pregnant women vaccinated, right? So at least when you have your COVID-19, your body has seen it already and has antibodies against it, or know how to handle the COVID-19. And I mentioned that those who are vaccinated have less prevalence of long COVID, so that can help. And they think it's because the body just knows how to react now to the COVID-19 infection. Some protection.
Thank you so much, Krista.
Is it this one?
Maria's online. Oh, she's online. Okay. So our next speaker is Dr. Maria Stephanie Fay Cagayan. She is recognized for her pioneering studies on gestational trophoblastic disease, or GTD, among women in the reproductive age group, for her publications that have helped put the Philippines on the international map regarding GTD and its management. Also for her academic contributions that will lead to the development of standards for the diagnosis and management of GTD, a disease still commonly observed among poor Filipino women. She is educated at the University of Philippines College of Medicine, and also in OB-GYN at UPPGH. Sorry, I'm not familiar, I'm a chemist. So, today she will be talking about trends in utilization of basic emergency obstetric and newborn care services in Luzon, Philippines during the COVID-19 pandemic, a mixed method study. Is she online? Yes. Okay.
Should we play your?
Yeah.
She's
So
actually.
yeah, I would just like to thank the organizers for allowing me to present this paper. I see some familiar names on the screen. My professors, Dr. Ronquillo is here. She was my teacher in biochemistry in the College of Medicine, and I have seen some colleagues from the NASD as well. So I have prepared a recording of my presentation, and I do hope that that would suffice, and I will just be standing by for the question and answer in a while. Thank you.
Dr. Cagayan is also Dr. Krista Serquina's professor.
Good day, everyone. I'm Dr.
12 minutes. And then you disabled screen share.
Oh, sorry. I need to. I need to make co-hosts. Do I need to make your co-host?
Yeah, pause at 2023.
Make co-host. Okay. Yes.
Maria Stephanie Fay Cagayan from the University of the Philippines College of Medicine and the Perinatal Association of the Philippines. And I am here to present the paper entitled Trends in Utilization of Basic Emergency Obstetric and Newborn Care or BEmONC services in Luzon, Philippines during the COVID-19 pandemic, a mixed method study. The COVID-19 pandemic altered the global health landscape. The direct and indirect effects of government interventions and service delivery adjustments resulted in increased maternal morbidity and mortality. Detrimental impacts on maternal and birth outcomes included increases in stillbirths, preterm births, ruptured ectopic pregnancies, and maternal depression. Institutional birth rates also decreased in birthing centers and in tertiary hospitals. In the Philippines, the first confirmed COVID-19 case was reported on January 30, 2020. Travel restrictions were implemented as early as January 28, 2 days prior to case detection. Local transmission was announced on March 7, 2020, and the country was placed under a state of national emergency the following day. The Interagency Task Force for Emerging Infectious Diseases was created to address the spread of the disease. Metro Manila was placed under Enhanced Community Quarantine or ECQ from March 15, 2020. Gatherings were prohibited and school and work were encouraged to use online setup. This was subsequently extended to the entire island of Luzon on March 17, 2020. The ECQ was initially planned to last only until April 14, 2020, but was extended until April 30, 2020. Afterwards, varying degrees of community quarantine were implemented in different areas. A dreaded complication of COVID-19 is maternal death. Data from the Philippine Infectious Disease Society of Obstetrics and Gynecology, coming from 6 referral hospitals in Luzon, showed a significant increase in mortality from 17 in 2020 to 51 in 2021. A strategy that is already in place since 2009 to reduce maternal mortality and morbidity even before the pandemic is the BEmONC package that enabled the performance of emergency obstetric signal functions at the primary healthcare level, such as the parenteral administration of oxytocin, magnesium sulfate, anticonvulsants, and antibiotics, among others. According to Roberton and colleagues, 4 health system components affect coverage of services: availability of health workers, availability of supplies and equipment, demand for health services, and access to health services. It assumes that provision of health services is a product of workforce and supplies, and that utilization of health services is a product of demand and access. Coverage is then presumed to be a product of provision and utilization of health services. This study aims to assess the effect of COVID-19 pandemic on the utilization of BEmONC services in Luzon, Philippines. And these were its specific objectives. A mixed method approach was used in this study, both quantitative and qualitative. This study was part of a bigger project by the Department of Health Philippines and the Perinatal Association of the Philippines with funding from the Philippine Council of Health Research and Development. Luzon is the largest and most populous island in the Philippines, where 57% of the total population reside. It is divided into 8 administrative regions and 81 provinces. Facilities were selected using a two-stage sampling method. In the first stage, provinces in each of the 8 regions were stratified into 3 according to maternal mortality ratio, with 1 province purposely selected per stratum. Government-run BEmONC facilities were selected in a stage using systematic sampling. A sample size of 244 facilities was targeted. All collected data regarding the availability and readiness of the health facility services were provided by the person in charge of the facility responsible for client services present at the time of survey. Monthly total facility-based deliveries from December 2019 to November 2020 were plotted in a single group interrupted time series analysis employing the Newey West estimator using Stata 14.2. Focus group discussions were conducted with 200 stakeholders, including 102 health personnel and 98 community members from February to March of 2021. All of the 8 regions of Luzon had 2 sets of FGDs, one with the local government unit and BEmONC personnel, and another with mothers and community members. All FGD recordings and notes were compiled and subjected to thematic analysis using NVivo 12. And these are the results. Of the 245 facilities surveyed, almost all had a stable electricity source and running water, but only half had a complete BEmONC-trained team consisting of a physician, a nurse, and a midwife. 1/3 had emergency medicines available at the time of survey. On average, facilities had 2 delivery beds and delivered an average of 7 babies a month, all of which were vaginal deliveries. The number of deliveries was not normally distributed, as 39% of facilities had at 0 average monthly deliveries over 12-month period. The entire Luzon had an immediate increase in the number of deliveries by 366 after the ECQ was imposed, from approximately 160 deliveries a month to around 1,900, remaining at that level until the end of the period covered. Regions 1, 3, 4A, and 5 contributed significantly to the increased deliveries during the pandemic. Regions 1, 3, and 5 showed immediate and sustained increases in the number of deliveries after ECQ was implemented, with deliveries increasing by 9 to 10 per month until the end of the 12-month period. Regions 2, 4B, Cordillera, Autonomous Region, and the National Capital Region did not have statistically significant changes in the monthly total deliveries pre- and post-intervention. NCR had an increasing trend in monthly deliveries prior to the lockdown, which tapered off during the lockdown. For the focus group discussion, there were 102 health personnel with the following profile. Most were doctors and midwives and were employed by the DOH. A number of the respondents were also program implementors. Only 35% had BEmONC training. On the other hand, there were 98 community members, of which majority were mothers. 73% were from urban areas, and most were high school graduates, multi-graduates, and delivered in the lying-in clinics. The provision of BEmONC services was constrained as health workers, supplies, and equipments became less available. Several BEmONC facilities closed or stopped providing services during the pandemic because they were temporarily converted into swabbing areas or isolation facilities. Bed capacity was reduced due to implementation of protocols and observance of proper physical distancing. Emergency vehicles and rural health unit ambulances were used to transport COVID-19 patients. Some BEmONC personnel were assigned to COVID response or contact tracing. Even if some BEmONC facilities hired new staff, most were not BEmONC trained as trainings were temporarily halted. Some staff members of BEmONC-capable RHUs were surprised by the sudden increase in their patients. In 3 regions, the COVID-19 pandemic led to an increase in BEmONC utilization. Since the onset of the pandemic, more mothers availed of the services in facilities as these were regarded as safer places than hospitals, especially tertiary ones that were converted into COVID referral centers. The propensity of COVID-19 cases in hospitals deterred pregnant mothers from giving birth there. This was especially true in the NCR and Region 4A, where even pregnant mothers from middle-income families used BEmONC facilities to avoid possible COVID-19 exposure. In this study, The results are consistent with observations in other countries. The increased utilization of BEmONC facilities may be a direct result of the decreased access to higher level facilities, which were converted into COVID-19 facilities. One study was conducted among expectant indigent mothers in Kilifi County, Kenya, who feared attending hospitals for perinatal care due to contracting COVID-19. A prospective study in India also identified fear of contracting infection as one of the main reasons for delayed health seeking. In Luzon, some provinces limited their BEmONC services to focus on their efforts against the pandemic. However, others did not because the need for primary care remains significant. The primary care safety net has been described as key to treating underserved populations and to providing surge capacity in pandemics. Universal health care should be prioritized with emphasis on reducing inequities and confronting discrimination, and to firmly establish sexual and reproductive health and rights at the center of these efforts. In conclusion, and going back to our objectives, despite the expected negative impact on maternal and newborn care services and facilities due to limitations imposed by the prolonged lockdown, BEmONC facilities in Luzon not only maintained their provision of services, but also had increased utilization in half of the regions. The COVID-19 pandemic caused a reallocation of resources and personnel and limited access to healthcare facilities for non-COVID cases. Government response to the pandemic has direct consequences for maternal and child health. Robust strategies for preserving safe and respectful maternal care must be a priority of policymakers and health leaders. Healthcare providers planning for service delivery must consider how to establish antenatal care pathways that explicitly reach out to vulnerable individuals and communities. A more comprehensive government COVID-19 response is also imperative in relation to the social determinants of health. Data suggests that the detrimental health and economic impacts of the pandemic are more significantly felt in developing or low to middle income countries like the Philippines. Thus, effective governance, better planning, and a more integrated approach anchored on primary health care are needed. As recommendations to ensure continuity and coverage of health services, BEmONC capacity should be improved and primary health care strengthened. Inclusive adjustments in service delivery involving community health workers in a comprehensive pandemic response are also warranted. To close, the authors would like to thank the team members and respondents of the assessment of the Philippine Emergency Obstetric and Newborn Care Initiative, a research study funded by the Department of Health through the Philippine Council for Health Research and Development. Thank you, and I am Dr. Maria Stephanie Fay Cagayan.
Thank you very much, Dr. Cagayan. Why am I not surprised that the births increased after the lockdown, especially in the Philippines? Sharp price. Oh my goodness. Okay, so any questions?
Why would you pray?
There's a question.
So there's a question. There's a side comment. This is actually very close to my heart because my mother is an RHU midwife. Is there an increase in COVID-19 cases among the actually the midwives, the nurses, etc. attending to?
Yes, ma'am. Actually, a big problem or a big issue during the COVID-19 pandemic was the decline in healthcare workers providing services for our mothers, mainly because they were at the front line. So even the midwives were catering to COVID cases, less of the pregnant mothers, but more adult, non-pregnant COVID patients. And of course, as I think all of us know that we were badly hit in terms of the COVID-19, the health personnel, a lot actually died. A lot of healthcare workers died during that period, especially during the first 6 months in 2020. And much of the problems arising in terms of provision of healthcare was actually the lack of healthcare workers. So there were the facilities were there, the equipments were there, but we had a lot of seasoned and trained health workers that really got very sick and died. And there were also young, the young health workers that were being put in the front line were actually less trained and had some of them were in terms of capacity for carrying out this emergency obstetric and newborn care services. They haven't been trained for that as yet. So it really has an impact. No, the mothers were giving birth in the primary centers, but the kind of or the quality of care that they are receiving might not be optimal. And what is not really shown in this report is that there was a big increase in home births during this period, because we weren't monitoring that. And one policy that the government has already put in place to make sure that we have reduced maternal mortality is that no mother should be giving birth at home. So every mother should be delivering in a facility, whether that's a primary care facility or a tertiary facility, wherever needed. But during the lockdown, definitely there was an increase in home deliveries. And there were not really too much deaths at this level because they were being seen at home and in the hospitals. And we didn't monitor or we didn't assess the tertiary hospitals for this study.
Yes.
Has there been a change? Has it shifted?
You'll have to come forward because she won't hear you from there. You have to.
Louder voice. Have you conducted
Right here.
follow-up?
Go to the screen, please.
Okay.
Yeah, right there.
Oh my gosh, sorry po. Have you conducted a follow-up study, and has there been a downward shift in the birth that you saw during COVID and post-COVID?
Yes, ma'am. We're currently doing this. This study was done in 2021. We're now starting with the Visayas and Mindanao phase of this study. We're conducting the similar study now in the Visayas and Mindanao, and we're quite excited to see changes in the trends as compared to what we saw in Luzon in 2021. So basically, since we're almost out of the pandemic now, we have seen lots of mothers coming back to the facilities for their prenatal checkups, but we're still in the process of getting new information and the evidence with regards to the changes in the trends as compared to what happened during the pandemic. So just to give a short background, the Philippines was not able to achieve the Millennium Development Goal of reducing maternal mortality ratio to around I think 52 per 1,000 live births. So we shifted now to the SDG, and it should be less than 70. So before the pandemic, we were on track. So the maternal mortality ratio for the Filipino women were actually less than 100 already. We were gunning for 70 for 2030. So it's now 2023. Unfortunately, with the pandemic, our data last year showed it again rose to more than 150. So we're way off track, and we're trying to go back again to how it was just before the pandemic, but I don't know. There are a lot of issues. I mean, health systems-wise, delivery of services that need to be addressed at this point. So I'm still a clinician, but I'm now more interested in terms of the public health aspect of the care for our Filipino women.
Thank you.
Thank you so much. Yes, please.
Hello, very nice study. So I was just wondering if you have a follow-up of the babies that were born from these mothers who are, are compromised during the COVID-19.
I am with another group which did a different study. It's a longitudinal cohort study which looked at both mothers and babies. So far, for babies that are less than 1 year old, there seems to be no difference yet in terms of the developmental issues as yet. Even with those mothers who contracted COVID, I don't think our data shows any significant change in terms of the development, both physical and behavior of these babies. But it's too early to say at this point. We don't know the long-term effects possibly. The first speaker, I think, is also from my same institution and is also an intermed student, used to be an intermed student. She was talking about long COVID. And I think I'm also interested to know if the mothers who had long COVID, but we didn't have any data on that as yet, would present with babies having problems. So it's actually a very, very interesting issue. And we're going to try to look closely at that as well.
Thank you.
And, thank you, Dr. Cagayan, again, for a very interesting talk that's actually close to me. So we go on to the next talk by Dr. Mariluz Mojica Henshaw. Yes. You have a question? Last question? You know what? Mariluz. Dr. Henshaw, who is not her, is currently a professor at the Touro College of Osteopathic Medicine in New York City and is a dedicated medical professional with specialization in biochemistry, human genetics, and regenerative medicine. She has extensive teaching and research experience in human biochemistry, basic stem cell biology, and molecular biology over the last 25 years. Prior to and immediately after pursuing graduate studies, Dr. Henshaw taught and coordinated.
That's one picture.
That's Virgin Dermal. That's Virgin Dermal. That's why I call it the middle town, but that's my name.
Okay. Human biochemistry. So she taught first year medical and graduate students at the UP College of Medicine in Manila. She did a medical research fellowship in immunology at the International Center for Medical Research at Kobe University in Japan. Pursued her graduate studies in human genetics at the University of Utah in Salt Lake City prior to joining Touro COM. Dr. Henshaw was a research scientist at the Cell Therapy and Regenerative Medicine program at the University of Utah, where she developed and executed research projects that were translational in nature, yes, and manufactured clinical grade HSMC, human MSCs for cell therapy. Dr. Henshaw is passionate about teaching and is thrilled at the opportunity to interact with and facilitate learning of students at Touro Com. And is she your daughter?
No. She's Virgin Dermal, the picture.
Yeah.
It's a colleague in Middletown. So she teaches physiology.
Oh, okay.
This is me. And so I was inspired by Mario, and so I'd like to invite all of you to please stand up. So in the last 8 years since I started in Touro, I've been doing wellness, so medical student wellness. And so I'd like you all to invite you all to stand up, even those.
Let's introduce you first.
Oh, no, that's my introduction. You did
So if you could all stand up, find a comfortable standing position. Let's relax. Okay, so feet hip-width apart. If you can imagine that there's a rope pulling on top of your head so that you are a straight back but relaxed spine, right? Okay, so now the first thing I want you to do is to notice your breath. Because it's only when you notice your breath that you're actually present in the moment. Okay, so ready? Sweep your arms up. And then sweep it back down. And then lift your right hand. Put it over your ears. Inhale, and as you exhale, lean to your right. Breathe in, breathe out, breathe in, breathe out, and then come back to center. Place your right hand to your side. Let's do it on the other side. So lift your left hand, put it on your right, inhale, and as you exhale, bend to the left. Breathe in, breathe out, breathe in, breathe out, and we'll come back to center, okay? So relax now, we'll do some shoulder rolls. So inhale, up, back, front, up, roll back, and front at your own pace. One more time, up, back, and front. The next one is my favorite giggle exercise. So lift your shoulders up, shrug it, squeeze, 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 and release. One more time, squeeze, 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 and release. All right. Next is, I'd like you to shake. We're not done yet, we're not done. Okay.
Time limit.
Yes. And I can tell you the results of my study in a while, but I think this is more beneficial to all of us. So that's why I'm making time, right?
Yes.
So as you're standing up, place your weight on your left because we're shaking the right leg. Place your weight on the left, lift your right hand, shake. Okay, place it back down. So get into a comfortable position. Put your weight on the right, lift your left foot, shake. Okay, then back. And this is the last one. We'll do 3 collective breaths. Breathe in, breathe out. One more time. Breathe in, breathe out. One last. Breathe in, breathe out. So good morning, everyone. Good morning. And let's get started.
Okay, so now that you're centered and in the moment, let's listen. Mariluz.
Yes, Mojica ako.
Mojica.
Yes. So we studied the impact of pandemic on the physical and mental wellness of our medical students at the Touro College of Osteopathic Medicine and also in our School of Health Sciences, which is in Bayshore. I know everyone is important, but medical students as a population compared to the general population is actually special because they're high achievers, right? Getting into school, especially in their first year, gung-ho about succeeding, and then basically having their first failures in their first exams. So it's a shocker of oh my gosh, this is my career that I want and I'm failing. And sometimes it snowballs. If I fail anatomy, the next one I'm failing would be physiology, and then biochemistry. And now you're deeper in the hole, right? So we're actually, and the other thing with that is they are actually having higher rates of depression and anxiety, even up to 8 times that of the general population. We also have a high rate of burnout and suicidal ideation. At the start, when I was reading the literature, it was all factoids until one of our graduates, who was a first-year emergency medicine resident, actually committed suicide. That really hit home. because here was somebody I knew. He was very active in Journal Club. He was an EMT by training. To me, he was always an emergency medicine doc. That was his life goal. And suddenly, like, what could have happened for him to decide that ending his life was the best possible out? But anyway, there are many, many factors, many stresses that a medical student, so from the personality, from the support system, they're from all over the New York or from the country going to New York, they're usually on their own, especially on their first year. There's the financial burden. Sometimes after the fourth year of undergrad medical education, this is 4 years of medical education, they incur about 400,000 in medical student debt. And that can be an astounding amount. So we try to promote wellness to be able to reduce stress by trying to train them in self-care activities. We have a wellness director who basically says that it should be student-driven. So you can, as a faculty, be gung-ho about wellness, but you have to ask them to invite you or let them know that you care about them enough for them to ask you to do it. So I do it sometimes when I feel that they're so stressed out at the start of my biochemistry discussion session. We do some of this, or I do a kindness meditation, just to be thankful and grateful for all of the things and all that. But the students are actually very active. They do physical activities, they have jogging sessions, they socialize, they have artsy-fartsy, they have medical students for arts, they have lunchtime that they draw and they paint. They have monthly, they post recipes. They're, oh, we're all busy, but let's do this. I tried this out, it was perfect, and it's healthy too. And so they try and be healthy and tell, oh, this is what Dr. Henshaw would be proud of us. And then suddenly we actually bring cookies to biochemistry. That's our carrot. Come to biochemistry, come to our clinical vignettes. And so we tell them this is sugar-free, calorie-free cookies whenever you are in biochemistry. But with the pandemic, what happened was that, of course, we know that it challenged the healthcare system, and more so with our students. It really posed a difficult time because now we had the lockdowns, the socialization that they knew they don't now have. We're lucky that Touro, in terms of a strategy, we're actually a flipped classroom. So everything was already online. They actually had to teach the teachers how to do the Zoom. So they let the students go home in early March, the first week in March. They're already encouraged not to come to school. And that was the time that we were actually beta testing how to hold the discussion sessions. So all of the lifestyle stages. And so Abby Santinello, who's actually the brainchild for this one, because she knew that I was doing 2 other COVID projects. So she said, can we do this? Can we do this together and just see? Like she was asking me that it might be a good way to at least document what's happening during the COVID pandemic. And also she said, maybe we can test too with an allied medical cohort. So here's the result. We did a single survey. It has 15 questions. We disseminated it online. The methods are slightly different. It's both online, but for our campuses, it's really via emails, whereas for the School of Health Sciences, they had this platform that's called Sona. It's an online platform wherein students actually come and participate in the research for credit for their as a research credit. So we did get increased participation from the School of Health Sciences. In terms of so we had to extend the studies time because the IRB was approved, but the SONA platform was not still on. So we had to extend that. Of course, participation was voluntary. So we had 407 completed responses. Most of them, because they were undergrad medical students, were actually 47% or 80% were on the 18 to 34 years of age. 74% were female. We had a number of, so 47% was Caucasian, but we did have African American, Latin, and Asian cohorts. The 4% is mixed ethnicities, and then the 9% was other because we didn't include the Mid-Easterners and all that. So they had, and they qualified it what their ethnicities were. So most of them still live, so I thought that they'd be all over, but they actually, most of them live still in the New York State, in an urban or suburban community with 1 to 4 other people. They were either in an apartment or in a single family home. And it didn't matter whether they were from COM or the School of Health Sciences. The apartment was about 50%, single family home was about 36%. 39% of them actually contracted COVID during the pandemic, but there seemed to be no pre-existing conditions. Of course, some of them had asthma, but it's not an overwhelming, and it didn't matter in terms of ethnicity. It didn't seem to increase if you were Hispanic or Asian or African American for that matter. 44% of them had experienced a death of a loved one during the pandemic. In terms of impact on weight, fire alarm. Oh, it's a drill. We're okay. Thank you. All right. So 36% had a weight gain. 25 had no change, but 21% had fluctuations, both up and down. The next thing, we had a long list that we said, so which ones of this were symptoms that you had? And pretty much more, so these are, the left side is those with more than 10%. They have decreased energy, difficulty concentrating, the weight changes, worry and fear, anxiety, panic attack. So these are actually symptoms of depression and anxiety, including the difficulty of sleeping, loss of interest, activities, being angry, irritable, the sadness, hopelessness, guilt, feeling of worthlessness, but some of them, 7%, did not have any symptoms. So we asked them, this is a self-report, do you perceive yourself to be physically healthy? And of course, there was a decrease between pre-pandemic to during the pandemic. The decrease is actually less in our comps, maybe because they had a lower baseline already to begin with. And then for the mental one, this was the one that was worrisome because there was a bigger drop for the ones in the osteopathic medicine. So they were really a lot worried in terms of their career paths because some of their clinical rotations had to be done remotely. And some of them did not have PPEs. Also, if they were allowed on the site, they did not have PPEs. It was depending on the site if they were given the PPEs. And then, so there were a lot of anxieties in terms of their training. So we've been trying to develop their wellness. So we were also asked, like, did they practice some of this during the pandemic? So some of them did walk, some jogged, yoga, Pilates, the high intensity interval training. So what I really value is the yoga and Pilates because the year after, so during and after the year, immediately after the pandemic, the year 2020-2021. So we had 4 yoga instructors in between the second and the first year of the osteopathic medical students. And we actually had Zoom yoga 4 times a week, different levels from gentle yoga to, they had power yoga on Sundays. It was actually way cool. I tried to attend all of them. Okay, yes, I'm all good. Because, yeah, so it was all good. So in terms of self-care, they were doing the family time, cooking, baking, exercising, the reading, so different things, which I felt was good because they were trying to help self-care practices, which we felt that if it was sustainable, then they could have it, because the part of the burnout in residency. So we were thinking that if we trained them as medical students to have the self-care activities, that it would, at least as a quality of life or a stress reduction, they know how to take care of themselves. Okay. So in summary, there's a decreased perceived physical and mental well-being. Some experience the depressive and anxiety symptoms. We did have a very low response rate, so that was the only downside. But what is more worrisome is the concern about so moving forward, like because, so in terms of socialization is a very important component of professional identity formation. And so part of this cohort now that's moving forward actually did not have enough of that, or not to the same extent as the previous ones. And so we were just wondering whether that would have, that's actually another study that we're also conducting. So of course, the more research and support for mental health. I've actually tried, so I cert here, so I wanted to ask, how do you do a buy-in? Because I've been trying to do a buy-in of our administration. There's a well-being index that you can procure. It's anonymized, but basically it requires a $10,000 subscription every year. You set it up, it's 10,000 to set up and 5,000 every year. So my one is, how does one get to buy in terms of a strategy? Because I feel that it's a very important component, not just for students, but also for faculty and staff, because there are resources in terms of well-being, and not just during the pandemic, but because this is really medical student life is stressful, and faculty life is stressful, and staff life is stressful. So we're all in this together. So between trying to a learning environment, that's important. So I'd like to chat with you about it, sir. All right, and on that, thank you very much for listening.
Very nice. I was wondering if you thought about, in terms of getting buy-in from the administration, if you try to do some kind of correlation analysis between those who had the best well-being index versus those that didn't with their board scores, over the time frame.
Okay.
Of course, I don't know if you could do that, but you can certainly make the case if you show this that there's a good correlation.
Okay. Yes.
So I know.
Thank you for that suggestion.
Most of your respondents were women. Actually.
Yeah.
And this is just a comment in my current job right now. So this year we commissioned the National Academy of Sciences to do a research on caregivers in STEM.
Okay.
So STEM people, scientists, who happen to be also caregivers, because that was a major issue for grant writing, or performing in being productive during the pandemic. And next year, possibly, we will have another National Academy Commission paper on burnout.
Okay.
Because both of those are very heavily influenced the performance of women scientists.
Yes.
During the COVID pandemic and even before.
Yes.
I was wondering, it's very hard to do to assess this. Did the experience of the people during COVID increase their compassionate nature? Because that's one thing that's being emphasized now in medical school, that it's not just subject, but also the holistic, the heart of the people. In fact, there's a woman who wrote a book on that. And I was wondering, since they went through this COVID, did they increase their compassion? Whatever that's called, Mr. Psycho Boy.
Yes, so I believe so, and I know it only from a few. So I interview the students who want me to write their MSPEs. They're in their third year, right? I know them, of course, and so they actually feel the excitement of being part of the clinical team. but they are also like, because they see the compassionate care given in the clinic by the physicians or the role modeling, they actually, yes, the answer to that is yes. There was increased compassion and increased patience too.
Very good. Yes, because I think we are bundles are full.
Yes.
You ask us, did you become more compassionate?
Yes. So Ed, did you become more compassionate?
Yeah,
yes, you what's your yes?
Yeah, we become.
No, he wants a better term. Kindness. He wants a trendy term.
No, I don't think we were more patient. Especially soon after COVID, we had to adapt to whether the students can come to class or not. And we were absolutely told not to do any online things, but I cheated and allowed my students who were sick to actually go online.
Even after.
Not force them to come to class.
Lucy? Oh, yes.
Yeah, you were reporting about the buy-in.
Yes.
This was taken from the medical students, right?
Mm-hmm.
And I think this can be expanded not only to medicine students.
Yes. Yes. Yes.
There are other programs or courses that reported also suicide.
Mm-hmm.
Some of them are COVID related, but some of them are beyond COVID.
Right.
But I am glad to understand that you have software or platform.
So there's a company that actually measures a well-being index. So they say that if you score 4 or greater in that index, you're at high risk for burnout. So we did a pilot because I wanted the buy-in. I did a pilot every quarter basically. So fall semester and then spring semester. But my bad, I didn't get to continue it because our dean wasn't warming up to the ideas. So I said, oh, but you're right. I shall in the what's this? I just have to move on and really do this is the proof. This is my proof, and whoever listens would be my source of funding.
And also
yes.
to within 1 minute. Okay, so the study is under subset. I'm exploring the MPHS and the process programs.
Yes.
Right. So I was trying to relate to the happiness index that was discussed already.
Yes.
About that is for the society in general, let's say for every country, and how can we relate the well-being index, happiness index to let's say, economic growth of the country or the GDP as discussed. Because I was listening to the comment that how it correlates to the board performance. I think that is wonderful to know.
Yeah.
And there are many other performance measures where this happen out, well-being index or happiness index can be related. And I have a big buy into what you're saying.
Right. Thank you.
There are no more questions. Our last speaker before lunch is Dr. Carlos Santos, MD MPHS. Is a transplant infectious disease physician and population scientist. His dual research career missions are to perform epidemiological and outcomes research that can help optimize infectious disease management in solid organ and stem cell transplant recipients, and also to build infrastructure applications and educational programs that will enable informatics and population health science research at Rush University. He is currently the medical director for the Rush Bioinformatics and Biostatistics for the site informatic lead for University of Chicago Rush Institute for Translational Medicine, and the course director for informatics at the Rush Graduate College. Dr. Santos, can you please come forward and
Alrighty. I don't know where the slides are, but
You have to go over.
Our break is until 1:30.
magandang umaga po sa inyong lahat. Ako po si Carlos Santos, isa po akong graduate ng Universidad ng Pilipinas, Diliman, in 1997, and then medicine in 2002. It's a privilege to talk before you today, before some people that inspired me to go into medicine and science. Dr. Tigno was my teacher in physiology. Dr. Berata was my teacher in molecular microbiology. Neither of them remember me from my time as a student. But it just goes to show, I think, the power of teaching and how you make an impact in your students' lives. Dr. Concepcion I've met because my good friend Bea I went to residency with. So it's really great to be among friends and maybe even family. So let's see. Oh, okay. And so, you know, during the pandemic, I think we all went through a lot. And so my academic output had to do with epi, biostats, informatics. So my field is the care of these immunocompromised people. And of course, COVID hit them very hard. But my tool, what I use to study my field is epi, biostats, informatics, data analysis. And so I went through a bunch of papers that explored COVID and its impact. And for each one, there was a theme. So for my first paper, it was fear. Because we all went through this fear of the pandemic, we could have died. I'm car-free. I happen to be car-free in Chicago. So I was biking to work. So I was afraid of dying, being hit by a truck, or by COVID. The second paper had to do with sorrow. And so we started to examine the outcomes of our patients with immunocompromise, and we found that the outcomes were terrible. And then during the pandemic, we were looking at a trial of transplanting people with HIV, kidney transplants in people with HIV. It was called the HOPE trial. At this point, the theme was hope. And so we were trying to see that we were going to survive this pandemic. And this paper that I'll present today has to do with resilience. So fear, sorrow, hope, and resilience. So hopefully nakaraos na tayo, and here we are today. So this paper is on the comparative antibiotic use in COVID and non-COVID-19 patients. And then just, yeah, I think you could do a slide to show that.
Yeah, there you go. Presentation.
Yeah, it's PDF. I don't know.
It's a PDF.
it's PDF, so it is okay.
It's okay. Is there a way? Is this
Yeah, fit the page. Yeah, if you take the page, I think I'll be fine.
present?
Okay. Perfect. Thank you so much for the help. And so this is our resilience paper. And so this is called the Comparative Antibiotic Use in COVID and non-COVID inpatients from 2019 to 2020. And these are my co-authors, a bunch of people with informatics degrees, infectious disease specialists, and some collaborators from the CDC. This was funded by the CDC. I consult for Merck and Pfizer, and I write for UpToDate. And so my career missions are to prevent and manage infections in solid organ transplant and stem cell transplant recipients, and I perform epi and outcomes research, and I help with our Clinical and Translational Science Institute, which is funded by MCAPS. These are my family members. We don't work in silos. These are my family members who were also frontliners in the time of pandemic. My partner, who's a scientist, my aunt with comorbidities, who's a nurse, her daughter, who's also a nurse, and my brother, who works for Philippine Airlines, who flew in repatriated Filipinos in time of pandemic. And this is my own response to the COVID pandemic. And so I talked about the fear paper, the sorrow papers, the hope paper, and now the resilience paper. And this was actually just accepted in infection control and hospital epidemiology. It's the first time I'm presenting this paper ever. I haven't even presented this paper to my university. So it's great to premiere here among friends. So the arrival of COVID-19 was marked by a lack of medical knowledge. And so we really didn't know what we were doing in March of 2020. And there were a lot of disproved management strategies, azithromycin, hydroxychloroquine, ivermectin, haphazard use of remdesivir. We didn't know what we were doing. And so antibiotic use was ill-informed, and there was reallocation of antibiotic stewardship resources. And so antibiotics were given to 80% of patients hospitalized with COVID-19 between March and October of 2020. That's some data from the CDC. But bacterial co-infections occur in only 4 to 8% of hospitalized COVID-19 patients. And this suggests overuse of antibiotics. And so any use of antibiotics can predispose you to allergic reactions, medication toxicity, C. diff, and antibiotic resistance. And so our goal was to compare antibiotic use in COVID patients versus non-COVID-19 patients in March to December 2020 and non-COVID-19 patients in March to December 2019, and to compare antibiotic use in non-COVID-19 patients in the COVID period versus the pre-COVID period. And our hypotheses were that there was greater use of broad-spectrum antibacterial agents used for hospital-onset infections in COVID-19 patients compared to non-COVID-19 patients, and that there's no change in antibiotic utilization for non-COVID-19 patients. As far as data sources, we leveraged existing informatics infrastructure for Capricorn. This is in 3 tertiary acute care hospitals in Chicago. We augmented it with bed location information. This was approved by the IRB. This is the data that we used. And we did some query development. This is the technical part of the talk, where we output the monthly number of antibiotic days and the monthly number of patient days. And we assessed antibiotic use in COVID-19 and non-COVID-19 patients. So these are the antibiotic categories as defined by the CDC. And these are the specific antibiotics that were frequently used in clinical settings that we tracked. And we performed Wilcoxon tests to look at the comparators. And so I'll get into the results. The information for each hospital are reported separately, and I'm reporting congruent and statistically significant differences in AU. Okay, so this is the part where I think I'll try to slow down, okay? So this is COVID 2020 versus non-COVID 2020, COVID 2020 versus non-COVID 2019. And then on the far right is non-COVID 2020 versus non-COVID 2019, okay? And this is a heat map of differences in antibiotic use. And so first, let's look at COVID 2020 versus non-COVID 2020. And you see a lot of red, right? So there was a lot of increased antibiotic use in COVID patients compared to non-COVID patients, and especially for broad-spectrum antibiotic agents against hospital-onset infections. And you see that across the board. There was also increased use of broad-spectrum antibiotic agents in major ICUs. Okay, so more antibiotics in people with COVID. And then we looked at non-COVID patients because we also wanted to see what it did to these non-COVID patients. And we found there was actually decreased use of antibiotics in non-COVID patients during the pandemic. And so if it's blurry, I think it's just the quality of the slide, so I apologize. And so there was a decreased use of antibiotics in non-COVID patients throughout the pandemic. And this is more antibiotics, so kind of drilling down into what we have. And so we saw a lot of increased azithromycin use, so over here. So, which, of course, it was promoted as a drug to fight COVID-19. In the end, it wasn't useful. There you have it. There was increased use of azithromycin, increased use of carbapenems, ceftriaxone, piperacillin tazobactam, and vancomycin. So across the board, you see a lot of red. There was just a lot of increased antibiotic use in people with COVID. And remember that only 4% of patients need an antibiotic. And yet you see a doubling of antibiotic use in people with COVID. So what does that tell us? It tells us that there was a lot of diagnostic uncertainty. We didn't know what was going to happen. We didn't know how to treat COVID. And so this actually gave me post-traumatic stress when I was writing the paper, because we lived through these terrible times. From March to December 2020, we were not vaccinated, our patients were dying, a lot of sorrow. And then I think that healthcare providers were responding to that by just throwing everything we had at these patients, trying to save them. At that time, we didn't know how to use dexamethasone or remdesivir. We didn't have vaccines, we didn't have antibodies. And so this was almost a Hail Mary. And that, I think, in the data is shown, and this is across 3 hospitals in Chicago. And so here's another way to look at the data. And so this is for all antibacterial agents. And you could see who the COVID patients are. And they're in the red. And so patients with COVID, you could see that there were marked increase in the use of all antibacterial agents across 3 hospitals. And for antibacterial agents against hospital onset infections, a marked increase in use of antibiotics. But then you see for non-COVID, it's quite stable and maybe even decreased, which suggests that for non-COVID patients, we knew what we were doing. Healthcare providers have been treating non-COVID patients for decades, centuries, so forth. And so we knew what we were doing. You see these very stable graphs in the blue. But for COVID-19, you see it's very choppy, it's increased. We did not know what we were doing. So again, that underlies just the amount of diagnostic uncertainty. This is azithromycin. So again, COVID-19 patients got a lot of azithromycin, especially in March of 2020, when we truly did not know what we were doing. It was being promoted as a cure, as a treatment, along with Plaquenil, hydroxychloroquine. Both were disproved in randomized trials. Thank you. And this is ceftriaxone, again, markedly increased in the beginning of the pandemic. So I think that this data really speaks, again, to diagnostic uncertainty in time of COVID. And so antibiotic use for broad-spectrum antibacterial agents, predominantly used for hospital onset infections, was greater for COVID patients compared to non-COVID patients in all 3 hospitals facility-wide, and in major intensive care units in 2 of 3 hospitals. And so antibiotic use for all antibacterial agents decreased in non-COVID patients during the COVID period compared to the pre-COVID period. And there was increased antibiotic use for broad-spectrum antimicrobial agents in COVID-19 patients. And this highlights diagnostic and therapeutic uncertainty. If healthcare providers don't know what they're doing, we tend to make things up. It's very unfortunate, which is why we need scientists really to tell us what to do. And so these high mortality rates in the beginning of the pandemic were really driving a lot of the therapeutic uncertainty. And so reduced antibiotic use for all antibacterial agents in non-COVID patients. There were marked changes in inpatient populations from disruptions in healthcare, and there might have been some resilient antimicrobial stewardship. Again, ceftriaxone and azithromycin were promoted, and we saw increases in uses of those. As far as limitations, we did not capture clinical scenarios associated with antibiotic administration. These databases we use, these are very large, and I think it's about 2 million per hospital, patients per hospital. And it's only refreshed every 6 months, and it's a 3-center study, which might limit generalizability. And so in summary, increased use of broad-spectrum antibacterial agents was isolated to COVID-19 patients, and use of all antibacterial agents was lesser in non-COVID-19 patients in the COVID period, and antibiotic stewardship programs remained effective, but maybe had not yet adapted to the complexities of COVID-19. And tracking antibiotic use in COVID patients will help. All right, that's it. This is Rush Hospital in the 1800s, and this is Rush Hospital now. So yes, yeah. Thank you for your attention. Yeah. Yeah. Yeah.
Is doctors trying to learn?
Did we learn? Yes, we are. And so it's sitting in my servers now.
Okay.
And in my copious amounts of free time, I will analyze it.
How would you call it? The last time was resilient. How would you call this period?
I think we're resilient. Yeah, I think. Yeah, I think we're in the resilience phase. And I think now after COVID, what we really need, if there's one thing I learned, is that poor people got hit the hardest by COVID, whether it's in the Philippines or here. And I think that we really should turn our attention now to helping the most vulnerable among us. Because if you look at the people that died from COVID, it was poor people. And it was really people with poorly controlled hypertension, diabetes, high cholesterol. And so if we're ever going to progress as a society, we need to go and look at decreasing diabetes, hypertension. So, all those calisthenics are very, very important. Exercise and eating right. Yes.
So obviously, like you mentioned several times, this is what we were doing, right? And the clinical practice guidelines for how to treat COVID-19 came months afterwards, right? Is there, in these hospitals mentioned, is there like a committee where you have to get for off-label use of antibiotics?
Yes, we have an antibiotic stewardship committee. But part of the challenge was they were refocused towards COVID, figuring out how to treat COVID. No one was looking after how to use antibiotics for people with COVID. That's where we saw this haphazard use. And also for off-label use of antibiotics, they were just overwhelmed. And so when azithromycin was being given, Plaquenil was being given, they were just overwhelmed. And also remember that even the NIH and the CDC did not speak against Plaquenil and azithromycin.
So there was no data.
There was no data.
Yeah, there was zero power.
Yes, Dr. Virata.
Yeah. With the clinicians shift to using the antivirals, antibiotics effective
against viruses, exactly. Yeah, they were treating super infection. And so when we see a patient that's getting worse, we don't know if they got super infected with bacteria. But of course, it's just the virus, right? And so we finally, the turning point was the Pine Tree trial. And so it showed that remdesivir, when given early, was associated with an 80% risk of death. So that was the turning point, but that was, I think, in December of 2021. So very, 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 very late. Decrease.
Albert?
That was in December 2020, right before the Omicron wave. So that's how long it took to show that remdesivir was the way to go, but it was very late.
You mentioned in the first couple of slides, ivermectin.
Yes.
So what's the result?
It's in randomized trials, there's no effect.
It's popular in the Philippines.
It's very popular. Yeah, for strongyloides, wala na strongyloides sa Pilipinas because of all of the ivermectin use. No, but it speaks to problems with access to. Poor people now can't get ivermectin to treat worms they actually have because rich people are hoarding all the ivermectin to prevent an infection and it's not effective. So again, questions about inequity. Yes.
You mentioned about the, socioeconomic factor. Are there really analytical or empirical analysis, or are these just anecdotal statements?
Yeah. So now it's very well documented. truly well documented. And so I practice in Chicago. And so if you have a map of Chicago, figure out where people died. It's really these 4 communities where people died. And let's not forget that the initial guidance to prevent COVID was to work from home. That's anti-4. What if you can't work from home? What if your job is to clean the bathroom at the McDonald's? How are you supposed to work from home? So that was really anti-4, and no surprise people died in poor communities.
So I don't know if you could do this, but have you looked at C. diff infections as a function of your populations that you looked at?
Yes, it went up too. Yeah, C. diff infections also went up in time of COVID because of all the antibiotic use that we were giving.
Would that have contributed at all to mortality?
Yes, for sure. Yes.
So all the patients were treated with the antibiotics, is there like an ongoing study to look at the long-term effects of the unneeded use?
Yeah, so we're tracking antibiotic resistance now. So we have another grant to look at antibiotic resistance over time. That's something that we're working on now.
Carlos, looking back now, this is looking back, what should we have done?
What should we have done? In retrospect,
In retrospect.
you know, you have to take scientists seriously. When the Chinese physician first alerted authorities about this new respiratory virus that seemed like SARS, he should have been taken very seriously. So I think that's number 1. Listen to your people in the front line. When they say that there's something wrong, listen. And number 2, don't mix science with politics, because you add science plus politics equals politics. So they were trying to keep kind of trade open. They were trying to still make money in time of pandemic. They didn't listen to scientists. Yeah, I would say those are probably the top 2. Number 3 is always bear in mind the vulnerable people. The most vulnerable among us will suffer the most. The richest among us got to retreat to their mansions. They were socially distanced and they worked from home. If anything, they got richer, right? And so for any kind of pandemic preparedness, for any kind of pandemic preparedness, bear in mind the vulnerable people.
Ignorance.
Yes.
We don't know anything. It increases variances, so the actions that we make could be totally not optimal.
Yes.
But I think the COVID episode also shows the importance of basic research.
Yeah.
Because without those basic research, we wouldn't have been able to develop the vaccine. So I think it's very important, even for adults, to do basic research, because that's the foundation that will give us the solutions. So,
and I don't want to let this pass. When I say I'm from NCATS, a lot of people say where?
Yeah.
And I'm so glad I actually found someone who is funded by NCATS.
Yes, I am funded by NCATS.
What's NCATS?
Thank you. We put it
Okay, I think it's time for lunch. It was a great discussion, but everyone's hungry by now. Oh, we have certificates. On screen. On screen. So we would like to give, Pastor would like to give the certificate of appreciation to our 4 speakers in this session. Krista Serquina, a grateful acknowledgement for imparting valuable knowledge and insight as plenary speaker.
The wrong side.
It's okay.
It's okay.
2023 Annual FASA Meeting and Symposium with the theme Reimagining the Training of the 21st Century STEAM Workforce, held June 26th to July 1st, 2020.
Thank you for the honorary PhD.
Moji, to Krista, to Carlos, and Stephanie. Okay, so are we leaving them or?
No.
They're virtual.
The lunch is served.
Thank you.
Thank you. Thank you to the online Santos, and Krista and Walter.
So we have, I totally agree with her.